We do it something like 20,000 times a day, and most of the time, we don't give it a second thought. But that simple act of breathing, it's an absolutely incredible mechanical and chemical process. So in this explainer, we're going to break down the science of how we breathe, from the muscles that make it happen to how we figure out what's wrong when it doesn't.
Go on, try it with me right now. Breathe in and breathe out. See? You just set in motion this really complex, totally vital chain of events inside your body.
Because in that one breath, a whole symphony of muscles, pressures, and gases started playing. So let's pull back the curtain and see how that whole symphony actually works.
All right, here's our game plan. We'll start with the pure mechanics of it all. Then we'll look at how we can actually measure lung function. After that, we'll dive into what happens when things go wrong, and finally, we'll see how doctors can piece together the clues to find the exact problem.
So first things first, how do we get air into our bodies? Well, you might think we're sucking air in, but it's actually the other way around. We're creating a space, and the air just rushes in to fill it.
It really all boils down to creating a vacuum. See, to breathe in, or inspire, your diaphragm pulls down and your rib muscles pull your whole chest cavity open. That expansion immediately drops the pressure inside your chest, and since nature can't stand a vacuum, the higher pressure air from the outside just flows right in to equalize things. And breathing out, that's the easy part. The muscles just relax, the chest gets smaller, and the air gets pushed back out. Simple as that.
Now, what's really cool is that all of this air moving in and out, we can measure it. There's a technique called spirometry, and it basically lets us watch a person's breath on a screen, turning it into data that tells a really detailed story. And this right here, this is that story. It's called a spirogram. See that gentle little wave? That's you, right now, just breathing normally. But these huge peaks and valleys? Whoa, that's someone taking the deepest breath they possibly can, and then forcing every last bit of air out.
And these squiggly lines give us some really key information. That small regular wave is called the tidal volume. That's just your normal, everyday breath. The total amount of air you can blow out after your biggest possible breath in, that's your vital capacity. And here's a fun fact. Even after you've pushed out every bit of air you can, there's always some left over. That's the residual volume, and it's super important for keeping your lungs from collapsing on themselves.
Okay, so that's how it's supposed to work. But what happens when this super-tuned system runs into problems? Well, most lung diseases fall into two big categories, and we have some pretty clever ways to tell them apart.
To figure out what's going on, doctors use a really important test. They measure how much air you can blast out of your lungs in the very first second of a hard exhale. That's your FEV1. In healthy lungs, you should be able to get about 75% of your total lung capacity out in that first second. And that ratio, of the first second to the total, turns out to be a huge diagnostic clue. And those clues usually point to one of two main problems. First, you have obstructive diseases, like asthma. Think of this as trying to breathe out through a tiny straw. The air is trapped, you can't get it out. The other kind is restrictive disease. Here the problem is getting air in. It's like trying to inflate a really stiff, small balloon.
You can see it so clearly on the graph here. On the left, the healthy person exhales 75% of their air in 1 second, no problem. But look at the person with an obstructive disease on the right. They're struggling to get that air out. Their total lung capacity is pretty normal, but they can only get about 50% out in that first second. That low ratio is the classic sign of an obstruction.
Now, check out the restrictive pattern. This is where it gets a little weird. The ratio is actually high, 90%. Because the lungs are so stiff, they just snap back really fast, pushing the air out quickly. The real giveaway here is the total volume, the forced vital capacity, or FVC. It's way smaller. They just can't get much air into their lungs in the first place.
But breathing problems aren't always about the mechanics, the pipes being blocked or the balloon being too stiff. Sometimes the air gets in just fine, but it shows up to a party where nobody else is. It's a logistics problem. This is what we call a ventilation-perfusion mismatch, or VQ mismatch. It sounds complicated, but the idea is simple. For your body to get oxygen, air, that's ventilation, has to meet up with blood, that's perfusion, in the tiny air sacs of your lungs. When that meeting doesn't happen right, you get a mismatch. In a perfect world, the ratio is about 0.8.
And in that perfect world, it looks just like this. Every single air sac gets a nice, steady supply of fresh air, and a steady supply of blood flows right past it, ready to pick up all that oxygen. It's a perfectly efficient system. But
What if something blocks a blood vessel, like a blood clot from a pulmonary embolism? Well, now you have what's called dead space. The air shows up, it's ready to go, but there's no blood there to meet it. All of that air, all of that breathing is completely wasted. The flip side of this is something called a shunt. In this case, the blood is flowing just fine, but it's going past an air sac that's collapsed or blocked. So the blood just cruises on by, goes back to the body without ever picking up any oxygen. It's like a train passing through a station, but the doors never open to let passengers on.
So, okay, we've got all these potential issues: obstructions, restrictions, dead space, shunts. How on earth does a doctor figure out exactly why their patient's oxygen is low? Well, they use some really clever detective work.
And one of their most powerful tools is called the AA gradient. Basically, it's a calculation that compares the amount of oxygen that should be getting into the blood with the amount that's actually in the blood. If there's a big gap, a big gradient between those two numbers, you know that oxygen isn't making the journey from the lungs to the blood like it's supposed to. And this flowchart shows just how elegant the logic is. First, you confirm the patient has low blood oxygen. Then, you calculate that AA gradient. If it's normal, the lungs are probably fine. The person just isn't breathing enough or the air doesn't have enough oxygen. But if that gradient is high, you know you have a real gas exchange problem, either a VQ mismatch or a shunt. So how do you tell those two apart? Simple. You give the patient 100% oxygen. If it's a mismatch, that fire hose of oxygen can usually overcome the problem and their levels will improve. But if it's a true shunt where blood and air never even meet, it doesn't matter how much oxygen you give them, it won't help. It's a brilliant way to find the exact point of failure.
When you think about it, from the simple contraction of a muscle to this incredibly complex matching of air and blood, our breathing is this constant, delicate dance. It really makes you wonder, what other invisible, perfectly balanced systems are humming away inside us right now just to keep us alive?